next example is a similar approach for a different joint. So in this particular case, we're going to go through end-stage arthritis of the talonavicular joint. And the shape of the talonavicular joint is actually, excuse me, very similar to the great toe joint. It's just a little bit bigger. So these are both ball and socket type joints, and historically would be somewhat difficult to access, especially for employing autogenous bone graft into this type of joint. But now with the advent of ArchiMIS and our newer, I guess, percutaneous and MIS techniques, we make this readily available to us now. Here you can see the patient's preoperative weight-bearing X-ray as well as their CT scan, which shows significant joint space narrowing. They also have some osteophyte formation and some subchondral bone cysts that are identified on that CT scan. So when preparing bone for fusion, these cysts oftentimes need to be eradicated and then backfilled with autogenous bone graft to get a successful fusion. A video of our joint prep. So in similar fashion, through a main working portal, we're going to be preparing the bone surfaces to create raw cancellous exposed bone on both the talar side and the navicular side. You can see we have some guide pins that were placed across the joint, and this was to put a distractor on. It can be somewhat challenging to distract these joints just because all the ligaments are still intact. And with the arthritis, it makes a very kind of slim, narrow, tight joint. So it can be somewhat hard to distract these joints. Once you get a little working space going, you typically don't need the distractor. So at this point, we have the distractor off. But again, like the big toe joint, you're going to prepare the joint and check it periodically with fluoroscopy until you're comfortable with your total joint prep before you deploy your autogenous bone graft. We've prepared our joint surfaces, and now we're taking a small drill to fenestrate the bone surfaces to create some fenestrations and holes in the bone that we can eventually then the next step being impacting our autogenous bone graft into the joint space and into some of these bone voids. Similar to the great toe joint fusion, here we're harvesting again from the posterior calcaneus, and this joint is a little bigger, so you can take a little bit more bone for this joint, and so that's what this is showing, is just harvest again from the lateral calcaneus. And then it's still a very small incision to go and harvest from the calcaneus. So on the bottom left there, you can see the closure of that site, which would still fall under a percutaneous approach. And then there's the high quality autogenous bone that we were able to get. In this particular situation, I did not have a tourniquet up, but oftentimes with the use of the Abicht bone harvester, that is the recommendation, is to use the tourniquet so that you don't get as much bleeding and coagulum, and you're just getting the bone itself. And then here's the scoop and the loading of the cartridges for the ArchiMIS on the back table. And again, pretty simple process here where I can still be preparing the joint and preparing the setup for the fusion while my back table scrub tech is loading the cartridges, and then they have them ready to go so that we're just ready to deploy that autograft into the joint and then place our fixation. So here you can see we're deploying through the same percutaneous incision that I was preparing the joints with. I have the cannula entered from a dorsal to plantar position in the talonavicular joint. And we're going to do this under fluoroscopy. And I'm going to try and load the plantar half of that joint first, and then back it out a little bit. We're going to change cartridges, and you can keep the cannula in the joint and just swap out the cartridge. And then you can deploy a second cartridge, and you essentially just keep deploying until you're comfortable with the amount of bone that you have filled that joint with before you compress it together. And again, I'm doing this through tactile sensation, but also checking periodically with fluoroscopy to see what that looks like. So you can see how easy it is to keep the cannula in and then to lock in another cartridge, and then you're ready to go to deploy more bone. So this system makes it very easy for the surgeon to focus on the fusion site itself, while other people can be preparing the cartridges, and all they have to do is swap them out to put more bone in. And here's our final construct. Again, in this situation, we placed 3 percutaneous compression screws which compress the talonavicular joint nicely and also compress all that autogenous bone that we were able to deliver through that percutaneous incision. And here's what the incisions look like. We have one main incision that we were working through to prepare the joint. And then the rest of the incisions are where the 3 screws went. And again, if you've ever seen a open procedure, typically this is going to be a long incision that, you're doing a lot more dissection on that anterior medial side of the ankle and the medial side of the foot to access this joint. So the benefit of this is smaller, cosmetically pleasing scars, and we did not disrupt all the typical soft tissues and the associated blood supply to these osseous structures by keeping it through a percutaneous approach. Just to kind of summarize, these are significant advancements really in the world of percutaneous and MIS foot and ankle procedures. And again, more options is better. And so now that we have this as an option, I can only see more and more joints able to be accessed and fused, as well as, like Maxim had earlier mentioned, bone cysts. And Dr. Carrington, I believe, is going to touch on arthroscopic indications. So really excited about this device in particular, as well as where the future is going.
Have you had any post-op yet visits with these patients, and maybe comment on how they were on their first post-op?
Yeah, absolutely. So I've had one post-op visit for both of these patients because these cases were fairly recent. We did not take any new X-rays or imaging, but I can say both patients doing very well in terms of their overall pain, swelling. Both of them rated their pain as a 0 out of 10 on their visual analog scale scores. We did not take their stitches out yet. Usually I do that at their second post-op visit. For the great toe joint fusion, that person is placing weight on their foot. They're able to bear weight, and that's my typical protocol after these percutaneous great toe joint fusions. The talonavicular joint, I am keeping non-weight bearing, and will likely do so for about 3 to 4 weeks, and then we'll likely let them start to do some partial weight bearing. But both from the standpoint of their post-operative symptoms are doing very well, and actually both commented on how they couldn't believe how small the incisions were, which is a pretty common thing that you get from especially patients that aren't familiar with these types of techniques.
And on the first post-op visit, the calcaneus harvest site incision specifically, they had no pain.
Correct. No pain for these patients. And, there are patients that, that particular spot, whether you take it from the calcaneus or the distal tibia or the proximal tibia, some patients do feel their harvest site more than they actually feel their primary procedure site. But in these two patients' cases, both of them were doing well without pain to any of those sites.